Today we presented NSABP B52. It's a study investigating the role of estrogen deprivation as a form of endocrine therapy when added to chemotherapy and dual anti-HER2 treatments in breast cancer. So the rationale for our study was essentially from prior studies and prior preclinical evidence that was generated in large part by our group at Baylor that showed that when the tumors are ER positive and HER2 positive, that both the HER2 pathway and ER need to be inhibited. Clinical trials also showed that tumors that were ER positive, HER2 positive, were less likely to respond to dual anti-HER2 treatments with chemotherapy than were ER negative, HER2 positive counterpart. So this led us to hypothesize that the estrogen receptor is a potentially pathway of resistance, in those patients, and therefore should be targeted concurrently with chemotherapy and anti-HER2. And we performed the study. Patients were eligible if they had ER positive, HER2 positive tumors that were 2 centimeters or larger or had nodal involvement. They were stratified by tumor size, nodal involvement, and menopausal status, and received either chemotherapy with docetaxel, carboplatin, trastuzumab, and pertuzumab, or that same regimen with added estrogen deprivation, which was a form of endocrine therapy, an aromatase inhibitor if the woman was postmenopausal, and an aromatase inhibitor plus ovarian suppression if she were premenopausal. We reported today the clinical primary analysis from the study and demonstrated that the rate of pathologic complete response in the breast and the lymph node, which is a primary endpoint, was 41% in the control arm and 46% in the experimental arm with added estrogen deprivation. This numeric increase was not statistically significant. We also reported the same trend in the pathologic complete response in the breast, complete clinical response, and as well as the rates of surgery. In all of those, there was improvement in the experimental arm, but that improvement was numeric and was not statistically significant. We noticed a significant toxicity from chemotherapy, which we knew existed, but we kind of were able to demonstrate it on a robust cohort of patients. The added estrogen deprivation did not add any toxicity. That by itself argues for a way to try and make treatments more effective and less toxic. The issue of the blunting might be that if the patients, if the tumors are treated with chemotherapy and endocrine therapy and anti-HER2, one treatment could dilute or blunt the effect of the other, and maybe we need to de-escalate that treatment, maybe take some or all of the chemotherapy out, and then target the estrogen receptor, maybe even more potently with more potent newer agents, and see if that strategy would work. A change in scheduling and sequence and probably a change in agents might be needed. Of course, on this study, we collected blood and tissue at several time points, and we're going to do some very detailed molecular analysis of those samples to try and understand the mechanisms of sensitivity and resistance, what subpopulations of the tumors were sensitive to chemo or anti-HER2 or estrogen therapy, and then see if we can actually discern the subgroup of patients that might benefit from one treatment or the other. Another thing we're going to do is we reported on the pathologic complete response, which is the absence of invasive disease. But there's plenty of evidence from other more detailed pathologic evaluation models, like the residual cancer burden, for example, is that sometimes a small amount of residual disease, which is clearly defined in those models, those patients could do just as well as the patients who have pathologic complete response. The other element is that, of course, the value of pathologic complete response is not yet established in this patient populations very well. And so we will need to continue to follow those patients long-term and see if there's any difference in their outcome, correlate those outcomes to the molecular characteristics of the tumor. First of all, the treatment that we gave is a standard of care treatment. The patient would have received that treatment after surgery. So what we did is just we moved it up front to see if you do it concurrently with chemo and with dual anti-HER2 agents, if we can increase the efficacy, kind of attack the tumor from multiple sides. The treatment did not add to toxicity. So it didn't add to the treatment of the patient, to the cost, or to the toxicity. However, the numeric increase was not statistically significant, so I cannot tell people that this is a more efficacious approach. For people who are, they need to consider this or discuss it with their patient if they are looking to maximize the pathologic response or maximize the chances of surgery being a breast-conserving surgery. However, again, because we didn't meet the primary endpoint, I cannot really recommend this treatment or not recommend it. All I can say is the results are out there, it's well tolerated, it does not increase toxicity, and maybe in some patients it may enhance efficacy. And I think that it should be a discussion between the patient and their physician what they decide to do with this data.